I talk about the clinical manifestations of pneumonia, and that, of course, based on our understanding to the pathophysiology. So we have a sick alveoli here. So there is an infection or inflammation. There's an immune reaction to that. As a result, there is an increase in the basal metabolic rate. That means increase in metabolism, which will increase the temperature of the body, so the patient will develop fever. This fever may range from low to high grade fevers. And of course, when the patient is febrile, his temperature is higher than the room, so that so the temperature will move from his body to the room or to the surrounding, and that causes chills. So these are some classical symptoms of pneumonia as an infection. Also, we know that the gas exchange takes place mainly in the alveoli. So now part of the alveoli, and depends on the severity of them of the pneumonia, is not functioning. So the amount of oxygen or the gas exchange will decrease. As a result of that, patient can experience hypoxia, and to make up for that, the patient may experience dyspnea. Also, this infection and this increase in the metabolism and this immune reaction will lead to killing the bacteria and some of the white blood cells, and that will produce sputum. So the patient will, of course, be coughing. And this coughing could be a hacking cough. If it's a viral, it will be more productive sputum if it's viral. And that's the type of sputum that we can use to culture and to see what microorganism is causing this infection. In the physical examination, this is very important. Again, when you understand the pathophysiology, you'll understand that you remember from physical examination that the lung area or the lung fields, the normal breathing sound is visceral. Now, if you hear bronchial, that's definitely abnormal, and this is a classical symptom for it's a classical in pneumonia. And another one it could be crackles. Now this is all because of the lung consolidation, which means that the alveoli now become more of solid instead of more of air-filled space. It's solid because of the pus that's accumulating. So the patient may also experience crackles. And a third classical findings in pneumonia is the increase in the ephremotus, tactile ephremotus. Again, when the voice moves through the trachea or the air, the voice and the vibration of the air transmits slower in the air. But when there's a pus and then the lungs become more consolidated, they will transfer more strongly, because the transmission is more strong. It was stronger at this point. So anyway, so that's why when you ask the patient, say 99 or 44 or light moon, you will hear that or you'll feel that the tactile ephremotus is increased. Now, as for diagnostic, after you obtain the history of the patient and a physical examination, you'll have now a more idea, and we come to a conclusion, as we call them, differential diagnoses. Now, to make a confirmed diagnosis, we need to do more studies. Now, one of the best diagnostic tests for pneumonia is chest X-ray. Now, what you would see in a chest X-ray, the lungs or the involved lungs, you will see more of the diffuse infiltrate, as you see in this picture. Now, let me explain a little bit how we read X-ray and how we use X-ray. Or actually, I'll do that in the next slide. The other thing we can do is to get a sputum from the patient and do culture and sensitivity. This is two different terms and important. As far as culture, you want to put the bacteria and see to identify the microorganism that's causing this infection. And sensitivity, of course, in order to identify what is the best antibiotics that can kill this microorganism. That's what we mean by sensitivity. So in the skills lab, we grow them, and then after they grow, the technicians will have several samples from the original sample and apply different type of antibiotics, and then you will be able to see which one is more the bacteria or the microorganism is sensitive to it. So you will see in the report sensitivity, may say that this microorganism is very sensitive to vancomycin, which means vancomycin is an appropriate antibiotic. You may see it's resistible. You see the letter R is resistible to penicillin, for example. So in this case, you don't want to use penicillin because it doesn't affect this microorganism, and so on. The other type that we can do also, the other test is the CBC. You just do a regular CBC to see mainly, of course, want to see the hemoglobin, but mainly the white blood cells. Now, white blood cells, they increase in number when there is an infection, and mainly the neutrophils, and that's the one that we're looking for. And so each one of these type of white blood cells, they have a specific percentage, and an increase in that percentage give us an indication. So for example, white blood cells, normally it's between 4,000 or 5,000 to 11,000. When they increase, then we suspect an infection. Now there are other reasons why the white blood cells will go high. So that's why we do what we call the differential. Differential means that I want to see what the percentage of A3 group of the white blood cells. So in this report, for example, you see that neutrophils are 75%, which is higher than normal, and that means that neutrophils are the one that are being activated, and that's an indication usually of infection. The other thing you see in this report is bands of 10%. Now bands should never appear. Normally, there should be almost zero bands Now bands, we call them bands, and some books will call it left shift, basically. These are immature neutrophils. And if you want to think about it, this is basically the bone marrow received signals that there's an infection, and we need many neutrophils. So now the process has to be expedited, so the neutrophils will leave the bone marrow and they're immature. You can think of this as if there's a disaster or if there's a war in a country where they have to use the youth, give them weapons and go to the battle now, 14, 15 years old. They're not trained, they're not matured yet, and so on. So that's what we see in neutrophils. So finding bands of 10%, that's very serious. That's a serious infection. That's definitely, it's an infection. Now with the chest X-ray, let me explain what chest X-ray. So there is an exposure. This is a radiation, all right? Now this radiation, the next step after exposure is absorption. Different tissues, they absorb different percentage or different amount of X-ray. Look at this. This is a normal chest X-ray. As you see, the white parts are the bones, and the bones are dense. The bone is dense, so it absorbs more of X-ray, and that's why it looks white in the X-ray. But while here this is air. Air is not dense, so the amount that the X-ray that the air absorbs is way less than the blood, for example, or the bones. So that's why it appears normally black. This is the heart, and the heart's filled with the blood, and blood is dense again, so it will absorb more of the X-ray, so it looks white. So in general, air normally appears black, and fluids, whether normal or abnormal, looks white. Now this is a patient that has a pneumonia. Again, if you see, you will see that bone. Here's the bone is dense and it's white, and this is the normal. The right lung is normal for this patient, so you can see the gas exchange there, or the gas or the air. It's possible for it to go to the right lung because it's healthy. While look at the left lung, you don't see air because it's filled with fluids, and that's why it looks here white on the X-ray. So that's what we call infiltrate. The other type is a sputum culture. Again, we talked about why we get a sputum. We either can ask the patient to cough it up, or if the patient is unable, we can get it through bronchoscopy, or we can suction the patient. And then there are some instructions are very important about the sputum culture in order to get the sample and to get a good result. First of all, because we want to identify this microorganism, we always, any kind of culture, whether it's blood culture, urine culture, sputum culture, always send it before you start antibiotics. Now, you don't want to keep the patient waiting for antibiotics because you're not getting the culture. So there's a window of 2 hours there. When the patient comes with the infection and it's confirmed infection, we should start the antibiotic as soon as possible. So you don't want to wait for a long time. So if you can get the sample before you start the antibiotic, so you don't kill the microorganism. The other thing is, we want the patient to take. You need to train them in deep breathing first, and then cough. And we don't collect saliva, because saliva has microorganism itself. We need to get the actual sputum. And the best thing, because overnight, because of the cilia, and the secretion will accumulate during the night. So the best time to get this sample is early in the morning. If the patient is not able to cough because of dry mouth, or we can give them fluids if not contraindicated. Now, if you're collecting a sample for culture, you know that it must be handled sterile. The cup, the containers that you get the sample must be sterile, and this should be sent to the lab as soon as possible. Now, the result of the culture can take 2 to 3 days. So we're not, of course, going to wait 2 to 3 days to know what microorganism is causing this infection, so we decide what antibiotics to give. But what we will do, we give what we call a broad spectrum antibiotics, and until we get the result of sensitivity to see if the medication that we're giving is working or not, we will decide to change it or add another thing. But if it's working, the patient will, the symptom will subside, of course. The other thing is, there are, for example, some microorganism that's causing 90%, let's say, of the pneumonia cases. So we know that it's most likely one of them. And that's why you can select any antibiotics that works for this one until you get the result of the cultural and sensitivity. Now, and I talked about the CBCs and what I mean by the neutrophils and the band and the immature neutrophils.